So this is going to be lecture on cranial nerves, kind of where the cranial nerves are in the brainstem, as well as we're kind of going to go over some lesions in the brainstem and what is the manifestations of the lesions. So for a review of this, it's best to look at First Aid 2023. There is histological pictures of the brainstem cross sections in page 518 and 519. You can use this in this lecture and any other resource you have to kind of fill that in to understand where really each of the brainstem nuclei and where each cranial nerve comes out of each section, as well as there's brainstem lesions of pica lesions on page 528 and 529. I'm kind of reviewing this one because I found it's extremely difficult in medical school, and there wasn't a great resource that had all of this, so I wanted to kind of go over it for you guys to make sure you kind of understand a little bit better. Perfect. So let's go into the different parts of the brainstem. So first we have the midbrain, most high up. Then we have the pons, second part, and then the lowest down, we're going to have the medulla. Sorry. So we have here's kind of around here is going to be your midbrain. Around here is pons. And around here is going to be basically your medulla. All right. So that's kind of the parts that we're looking at. We're going to kind of go over where each, well, actually, first let's go over each descending track. So the first descending track that I really want to go over is going to be our corticospinal tract. I'm just going to label this as CS corticospinal tract. So corticospinal tract will, and another thing to look at, this is a histological view of it. So this is the anterior portion here, and here's posterior portion. You're basically doing a transverse cut and looking at it from the top. In radiographic, if you're looking at it radiographically like an MRI, you're taking a transverse cut and you're looking at it from the bottom. So remember, this is going to be a little bit flipped when you look at it from histological, which is kind of correlates with page 518 and 519, and radiographic like an MRI, where it's going to be flipped. So this anterior portion is actually going to be more up here, and the posterior portion is going to be in the back. All right, so corticospinal tract in the midbrain, it's right here. We'll kind of go into the lesions of this in a little bit with some test questions. So here's the corticospinal tract in the midbrain. As it goes down into the pons, it stays kind of anterior and medial. So here's your corticospinal tract here, and as it goes to the midbrain, it goes into kind of like those medullary, in the medulla, it goes into the medullary pyramids, stays medial and also anterior, and it goes right here. Now remember, if you get a lesion in here, it decussates in the medullary pyramids, so these cross, so you're going to get a weakness, motor weakness on the contralateral side of the body if you have a brainstem lesion. All right, so that's your corticospinal tract. Next track we're going to do is going to be your medial meniscus, and I'm going to do ML for medial meniscus. So where is the medial meniscus located? The midbrain is actually a little bit lateral, so it's right here. So here it is in the midbrain. But as it comes down, it once again gets more medial. So it's medial more in the pons, and it becomes very medial once you get down into your medulla. It also, remember that like synapses in the nucleus gracilis, I think in cuneatus, in the medulla and crosses over. So once again, if you have a lesion in the brainstem, it's going to give you contralateral sensory loss in the form of proprioception and light touch. All right, next one, we're going to kind of stay in sensory, and this is going to be your spinothalamic. So this is kind of that pain and temperature sensation. All right, so for spinothalamic, I'm going to put ST. So where's the spinothalamic tract? It's going to be right around here in your midbrain. As you keep kind of going down for your spinothalamic tract, it stays pretty lateral. So it's lateral right here as you keep going down through the pons. And then once you get down into the medulla, it stays pretty lateral as well. And you see your spinothalamic tract here. Now these decussate more down in the spinal cord through the anterior white commissure. So once again, if you have a lesion in the brainstem, it's going to be contralateral pain and sensation on the other side of the body. Last one that we're going to do, we're just going to label for our descending tract. And I'm going to put these together. I'm not sure if this is like a great idea, but we're going to do the spinocerebellar track, and we're also going to do, I'm going to put this together with the rubral spinal track as well. So let's start for this in the midbrain. So here is going to be your red nucleus. Now this is kind of part of your rubral spinal tract, not exactly part of your spinocerebellar tract, but it does receive input from the cerebellum, so it can cause similar manifestations. Though rubral spinal tract, as it crosses over from the outside of the cerebellum, goes to the motor cortex, comes down, it's going to be ataxia and sometimes tremor on the ipsilateral side of the body, where now we're going to label the spinocerebellar tract. Here's the cerebellar peduncles and the pons. You can't see the cerebellum right here, but just know that this area kind of goes to the cerebellum right here, and here is going to be your input from the spinocerebellar tract or cerebellar tract in general in your medulla. So if it affects here in the pons or medulla, it's actually going to be ipsilateral ataxia. And the reason why it crosses over twice, so it comes back to the ipsilateral side, giving you ipsilateral ataxia if it's in the pons or medulla. If it's that red nucleus, which is actually part of the rubrospinal tract, it's going to be contralateral ataxia. It can also give you this specific kind of root tremor as well. So those are your descending tracts. One that I'm not going to actually label, but just know that it is on the lateral portion. That's a descending tract is going to be your sympathetic tract. So if you get a disruption with your sympathetic tract, this can give you ipsilateral Horner syndrome. So that like ptosis, anhidrosis on that side of the face, and then as well as a very small myotic pupil. You may get as well from disruption of sympathetic innervation. I'm not going to label it, but just know that it's on the lateral side. It's a kind of a descending or ascending track in the brainstem. Actually, let's change this. I think it's descending, but it could be descending or ascending. Basically, a track that goes through the entire brainstem. All right, descending or ascending track, but it goes through the entire thing. All right, so now let's go over our cranial nerves. So cranial nerve 1, olfactory, not going to be labeled here. It doesn't really go into the brainstem. 2, optic nerve, also doesn't really go into the brainstem, so I'm not going to label it. So then we get to 3. So 3 is going to be your ocular motor. So where is the lesion for the ocular? So where's the nucleus for ocular motor? It's going to be right around here. All right, so here's your ocular motor nucleus. Lesion in this is going to cause ipsilateral motor dysfunction, that kind of down and out gaze to that side. May also cause a dilated pupil as well. So these kind of start right here, and then they go through the red nucleus and out through the anterior portion of the brainstem, through the red nucleus, out through the anterior portion of the brainstem. All right, so that's your ocular motor. Next, we're going to do trochlear. Okay, so trochlear nerve is going to be our cranial nerve 4. Here, it's a cranial nerve 4 is going to be trochlear. Now, trochlear is a little, it's not involved in many lesions, but it's located right here, but it actually crosses over to the other side. It's the only one that really crosses. Oop, actually I wrote that wrong. It's the only one that really crosses onto the other side of the brainstem. Alright, so they're going to cross paths and kind of go out the posterior portion of the brainstem as well. So this one's going to go out this way, the posterior portion, and this one is going to go out this way. Alright, so there is your trochlear nerve right there. Not involved in many lesions, but remember it does go to the opposite side. Next, we're going to get into cranial nerve 5. So to ask yourself, maybe what is cranial nerve 5? You can use one of those acronyms that are commonly used. Cranial nerve 5 is going to be your trigeminal nerve. Cranial nerve 5 is a little bit weird in that it is present in the pons. So be present around here. In the pons, it's kind of in your lateral portion, and it kind of stays in that lateral portion when you get down the medulla. So it crosses a little bit. It's a very long nerve nuclei, so it crosses from the pons and the medulla. And remember that is a little bit of motor, so it does the muscles and mastication, but it's mostly sensation really from the face. All right, so remember that sensation of the face. Then we're going to get cranial nerve 6. So cranial nerve 6 is going to be right here. Your abducens nerve. So abduction of the ipsilateral eye. And they're going to go out basically the interior portion of your brainstem and your pons. A little bit weird, and this probably isn't drawn perfectly, but the next one you're going to think about is cranial nerve 7. So where does cranial nerve 7 is going to be your facial nerve. This is going to be a motor nerve, as well as what taste, I think, from 2/3 of the tongue as well. The facial nerve is going to be right around here. And where the facial nerve, it actually comes up and loops around the abducens nerve before leaving. Alright, so it's a little bit more lateral, but it actually does go ahead and loop around your abducens nerve, and then it leaves your brainstem laterally. Next, we're going to have cranial nerve 8. And test yourself, which one is this? This is vestibular cochlear. So vestibular system, if you mess this up, you can get some ataxia, as well as cochlear, so hearing loss. So messing this up can give you not ataxia, sorry, vertigo. Can give you vertigo if you mess this up for the vestibular system. Difficulty walking, as the vestibular is kind of system's a bit of your internal gyroscope. If you don't have that, you can absolutely have some difficulty walking, which you can see with the brainstem stroke with ataxia, as well as cochlear, which is going to be hearing loss. All right, so vertigo and hearing loss, kind of a simplification of that as well. All right, and next we're going to get to what are the cranial nerves and the medulla. So these ones get kind of tough, especially when you start looking at 9 and 10. So 9 and 10 are a bit together. They have a lot of, we're not going to go over their nuclei, the specific names of it, but they have a lot of the same nuclei. So the nuclei are right around here. Once again, these nuclei probably aren't all going to be in the same exact plane. I'm just drawing them in for you guys to make this a little bit more simplified. All right, so they kind of draw the same nuclei there. A lot of them involved in 9 and 10 is like, so 9 being glossopharyngeal, 10 being vagus. A lot of it is involved in palate elevation as well. So you're looking at palate elevation is a good sign for glossopharyngeal. But swallowing also has some innervation from the vagus nerve, then also obviously your autonomic input from the vagus nerve as well. So these kind of come a bit together into the same exact area, but when they do leave the brainstem, they go out into your vagus and your glossopharyngeal. So kind of the same side. Once they leave, they go out into two different. It doesn't look very good with your vagus and glossopharyngeal. And then the way that you're really going to test this, just on a cranial nerve exam, is look for palatal elevation. Have the patient say ah, and look to see if there's symmetric palate elevation, mostly for your glossopharyngeal, but there's some input with swallowing to by the vagus as well as obviously that autonomic dysfunction. 11 is not exactly going to be shown here, but your 11th is your accessory nerve. You're not going to see the nuclei in the medulla, as you kind of see there a little bit further down where it comes out. And then lastly, oh, I drew this a little off. And then lastly is going to be your hypoglossal. Going to be right here. Can control your tongue. If you get a lesion, it's going to lead to ipsilateral deviation of that tongue, and then you get the patient to keep your tongue out. And this is basically where those cranial nerves go to for your hypoglossal nerve. All right, so 12 is your last one. It's going to be more medial. It's going to be your hypoglossal. All right, so that is a general overview of where these nerves are. Obviously, there's going to be some minor nuances. Like I said, I tried to make a 2D representation of 3D structure. They're not exactly all in the same plane. In this way, I put them in the same plane, and a lot of things were oversimplified, especially my combination of the spinocerebellum and the rural tract, which has a lot more go into it. But this is just a general overview of basically where all these cranial nerves are and some of the functions that they do. There is an easier way. If you're a visual learner, you can remember it by looking at this. If you're not, there is a nice way to remember, and this is called the rules of 4. So just remember 4, M, and S. I think 4, M, and S is going to be really helpful. So remember there's 4 midline structures. So we went over this already. We saw that the corticospinal tract was midline. The MLF, I didn't really put in too much. The MLF is synchronization of your eye movements. It's a very heavily myelinated tract, so MS can mess this up, and you can have unsynchronized eye movement, especially abduction, adduction as well. I didn't really tell you where it was. MLF is mostly right there, right here, probably right here as well. So that's what that does. And then there is your medial luminous, because we want to have that's more of a medial structure. It starts with M. And a lot of your motor cranial nerve nuclei are going to be medial as well. There's going to be 4 side structures. So remember the S's, sympathetic. So a lot of the lateral lesions are going to give you sympathetic abnormality. Sympathetic lesions, and ipsilateral hornal syndrome, spinocerebellar, so ipsilateral ataxia, unless it hits the red nucleus in the midbrain, which is going to give you contralateral ataxia and tremor. Spinothalamic is going to be on the lateral edge, and then your sensory nerve for cranial 5, your trigeminal nerve is going to be on the side. Next is, remember that the rules of 4, 2, so somewhat 4 cranial nerve in the medulla, 4 in the pons, 4 in the midbrain, though really only, but really these aren't as much in the midbrain as in more near the temporal lobe, but remember that 3 and 4 are going to be in your midbrain. Pons is 5, 6, 7, 8, so 4 of them, and then medulla is going to be 9, 10, 11, and 12. All right, so there's somewhat nuances where these are the 1 and 2 really aren't in the midbrain. You can remember it as such, as it's easier to get them into 4 per each spot. And it kind of divides pretty nicely. And when you're going over the 12 cranial nerves, this makes it a lot easier to know where it was and to localize a lesion as well. Some very specific lesions is going to be 3, obviously, and if it's a cranial nerve 3 lesion, it's probably going to be in the midbrain. If it's a cranial nerve 7 lesion, you really know that it's going to be in the pons, or if you have loss of hearing, it's going to be in the pons. And for the medulla, if you have, problems with glossopharyngeal and vagus, which a lot of with your palate, they're going to have difficulty with raising the palate. They're also going to have some dysphonia, dysarthria, inability to talk, as well as dysphagia. So a lot of the dysses, because they have abnormalities of palate movement, pharyngeal movement as well. Another one that's really specific to the medulla is going to be that 12. So hypoglossal nerve abnormality is going to be very specific to the medulla. So if you see that, that's where the lesion is. Also, it's motor. And another one that we can go into, dividing into 12, that's going to be pretty medial. So the 4 motor nuclei divisible into 12. So 3, 4, 6, and 12. These ones are also going to be very much medial, so it's going to be more of a medial lesion. So M, medial, somewhat motor, as well as the other ones are going to be more on the side too, and it's a lot of your sensory cranial nerves. And then I don't know if I went through this, but yeah, so it's kind of your rules of 4, which is just this just goes over it a little bit more. The 4 medial structures, them, and the 4 stride structures. The ethos with just a little bit better explanation of it. So if you don't like it visual, like this, if you really remember these rules of 4 midline structures that start with M, 4 side structures start with S. There's 4-ish cranial nerves in the midbrain, 4 in the pons, and 4 in the medulla. And then there's 4 side structures as well that should usually start with an S, which would mean that sympathetic, spinal cerebellar, spinothalamic, and sensory cranial nerves 5. So the rules of 4 is going to be very, very helpful. Honestly, I'm not going to remember later on in your career. You're probably going to remember where every single thing is. You might need this for your lab practical, but you can still remember the Brainstem rules of 4. And if you know this, if you learn this, if you understand it, you can localize a brain lesion without knowing exactly where they are visually. All right, so let's do some cases. Case 1, and I want you guys to test yourself and try to localize where you think this lesion is. So it's sudden onset, and things that are such sudden onset in medicine are usually vascular things like strokes, electrical things like seizures, arrhythmias, as well as rupture or blockage of internal organs. In this case, it's a stroke. The right eye gaze is down and out. There is diplopia of the right eye, ptosis of the right eye. There is a afferent pupillary defect, the right eye, so you shine a light in there, it doesn't constrict, and there's left-sided hemiparesis. Question is, where is the lesion? All right, and the answer, and what is this syndrome called? So the lesion, this is called, so let's go, this is in the midbrain. All right, so let's kind of go through this. So the midbrain, there's a couple different lesions that you can get. The first lesion we're going to go through is going to be Weber. So what is Weber syndrome? So if you this is a drawing of all of your arteries. So we got your vertebral arteries here. Vertebral arteries kind of come up. You have the pica that comes off of it and feeds the lateral portion of your medulla. You have your ASA that comes off of it that does the medial portion of your medulla. That then goes up to the basal artery. The pica, we went through the pica already. The pica is down, feeds the medulla. The ica feeds the lateral portion of your pons here, so you can kind of see that blood vessel feeding the lateral portion of the pons here. It goes up to your basal artery, gets a paramedial abrasion of the basal artery. And then it goes into your SCA, superior cerebellar artery, and the PCA, which mostly supply the midbrain. So this is an infarct, probably somewhere in your SCA or your it's going to be right-sided, so let me delete these. Right-sided SCA or your PCA, some of the branches that come off that supply the midbrain is causing Weber syndrome. So where is this infarct in general? So drawing this here, this infarct gets a bit of the corticospinal tract. I didn't go over, but the spot I'm in right now is part of your is the substantia nigra, which projects up to your basal ganglia. Sometimes can be involved in this lesion as well, and it also hits where your ocular motor nerve comes out. All right, so you get ocular motor nerve palsy on the ipsilateral side. So this guy is an ocular motor nerve palsy on the ipsilateral side. It's a right-sided stroke. The right eye gaze is down and out. There's diplopia, ptosis, ocular motor, and there's afferent pupillary eye defect in that right side. So there's ocular motor nerve palsy hitting that yellow. But at the same time, you're also hitting the corticospinal tract, so you get that contralateral weakness to the body. All right, so this patient also has left-sided, the stroke's on the right, left-sided hemiparesis because it's hitting this descending corticospinal tract. That's Weber syndrome. There's some other syndromes that happen in this area. You may not be tested on it, but I think it's reasonable to go over. Another one is Benedict syndrome. And what is Benedict syndrome? So a little bit different, also hits the corticospinal tract, but here kind of hits the red nucleus, the rubrospinal tract. So for these patients, you're going to get ocular motor nerve palsy, and at the same time you're hitting that red nucleus, so you're going to get like ipsilateral, so that kind of receives input from the cerebellum. That input goes up to the motor cortex, and then you can get ipsilateral, and then, sorry, not ipsilateral, and then it goes down, so sorry, contralateral. So contralateral ataxia, tremor. Alright, so it's not like from the spinocerebellar where it crosses twice, it only crosses once, so you get contralateral ataxia, and you get this kind of what they call rubal tremor. We won't go into too much. Last one is if it hits all of this, all this area at the same time. This is called Claude. So Claude syndrome equals both. Alright, and this could be, I think probably more of an infarct would be SCA, but also could be PCA. Remember the SCA and the PCA, which is the superior cerebellar artery, is the SCA, and the PCA is the posterior cerebral artery. Supply the midbrain, so it's infarct, maybe one of the branches off of one of these arteries. All right, so those are your main. Those are going to be your main midbrain lesions. It's going to be Weber, where it's oculomotor, corticospinal. Benedict syndrome, which is going to be your oculomotor and your red nucleus or rubrispinal tract with contralateral ataxia and sometimes tremor, or Claude, which is really both. Okay, so that is your midbrain lesions. And if you don't forget, remember the rules of 4, and you would have gotten where this was localized just by the fact that you hit cranial nerve 3, which, the first 4 are in the midbrain, so cranial nerve 3 is in the midbrain, the patient has cranial nerve palsy. And you can also get this by the fact that it's medial, because ocular motor is 3, it divides into 12, so it's motor, and it is motor, so it's more midbrain structure as well. These are general. This is not like a perfect. This is probably not an absolutely perfect mnemonic, but it's definitely really helpful. So you know that it's medial as well, so it's more from medial infarct. And then it helps you that it starts with an M for motor cranial nerve nuclei down here. Okay, so you got all the M motor cranial nuclei is kind of divided into 12, so you got 3, 4, 6, and 12. Perfect, so you can localize it by knowing where it is visually or by going over this rules of 4. Alright, next one, case 2, sudden onset. Right-sided facial paralysis, right-sided Horner syndrome, right-sided ataxia, dysmetria, I doubled this up, but right-sided Horner syndrome, really wanted to emphasize that, right-sided loss of hearing, right-sided loss of temptation and pain to the face, but left-sided loss of pain and temperature of the body, as well as nystagmus vertigo. Question is, well, first ask yourself, where are we? Are we in the midbrain? Are we in the pons? Or are we in the medulla? And I think that's not super hard because you know that there's cranial nerve 7 involvement, 7 is in the pons, as well as there's a vestibular cochlear involvement too, with that loss of hearing also present in the pons, and you know that there's some trigeminal involvement, not as specific because there's trigeminal in the medulla as well, but you also have some vertigo too, which can be vestibular cochlear, also cerebellar. But you kind of at least localize, this helps you localize yourself to the pons, especially with that right-sided facial paralysis. Next is, are we medial or lateral? There's a lot of S's here, right? So sympathetic tract is an S, spinocerebellar tract is an S as well. We have some sensory things like cranial nerve 5, which is an S as well. So these things can all be pretty helpful here for localizing you to the lateral portion. The question is, where's the infarct? All right, so this would be called lateral pontine syndrome. All right, so lateral pontine syndrome. And where's the infarct? So the infarct's lateral and they're pontines, right? So it definitely includes that spinocerebellar tract right there. Includes your cranial nerve 5. Does not include your abducens. That would be more of a medial pontine syndrome. Includes up here with your cerebral peduncles, so you have ataxia. I'm also outlining your vestibular cochlear, trigeminal. For some reason, it's only pain, sensation and pain to the right side of to the ipsilateral face in this section, right? So here, lateral pontine syndrome, we've got a couple. We have the spinocerebellar, so contralateral loss of pain and temptation to the other side of the body, and here's the left side. We have ipsilateral facial nerve palsy. We have hearing loss and vertigo, hearing loss to the ipsilateral side, so you have the cranial nerve 8, which is vestibular cochlear palsy. We have the trigeminal nucleus, which gives you pain and temperature loss to the ipsilateral side of the face. And then also, I don't draw this in, but just know that the sympathetic tract is lateral. We also have Horner syndrome, so sympathetic tract. So that's going to be your lateral. It's like Marie-Falk syndrome, but it's going to be your lateral pontine syndrome. Okay. Good. And remember, it doesn't include a lot of the medial structures, including corticospinal. So this is not included. Medial lemniscus is not included, so you're intact. Intact proprioception and light touch to the opposite side of the body. Does not include your abducens, so you don't actually have a cranial nerve palsy here as well, because those are all more medial structures. All right, 2 more. And this is another review of that rules of 4, which is very helpful, especially further down the line when you forget where all these things are. All right. Case 3, sudden onset, vertigo and ataxia falling to the right-sided Horner syndrome. Is that right? I'm going to not include, I don't think this is totally correct here. I'll not include that. Yeah, this is an error. Don't include this. It's more medial. You are going to have left-sided pain and temperature loss, and then you're going to have hoarseness, dysphonia, dysphagia, dysarthria. All right, so where are we? Are we in the midbrain? Are we, the first question, pons or medulla? And the thing that's going to be most specific is the cranial nerve 9 and 10, which palate, pharyngeal, motor function, as well as sensation as well, is affected, right? So you know by the rules of 4, you're in the medulla. The next part is, and the one thing I didn't go over, sorry, for the last one, is for the lateral pontine syndrome, where's the infarct? So if you want to look here, the infarct is going to be at your ICA, all right? So here it's going to be ICA, and actually on the right side, so infarct of the ICA on the right side, because that is a lot of blood supply to the lateral portion of the pons. So here's your blood supply to the lateral portion of the pons. You're infarcting here, so this is a ICA lesion for lateral pontine syndrome, which I didn't go over. All right, but anyway, let's go over case 3. Now the question is this medial or is this lateral? And we know what things are medial: 3, 4, 6, and 12. This really isn't 3, 4, 6, and 12. Here you have 8 and 9. These are not divisible by 12, so you think that they're more on the lateral side as well. We also have some other things of lateral. We know that the sympathetic is on the lateral portion, is lateral. We know that the cerebellar peduncles is lateral. We know that the spinothalamic is lateral when we're in the medulla as well. So we know that we're more on the lateral side. So where's this lesion? This would be a lateral, let's do maybe red, lateral medullary syndrome. And this we would call Wallenberg. So we also call this Wallenberg. All right. So what's hitting Wallenberg? It's lateral. So you're hitting kind of all these areas. So we have spinothalamic right here. So spinothalamic is going to be messed up. So you're going to have contralateral pain and temperature loss. We see that 9 and 10 are going to be messed up. So this patient doesn't have a lot of palatal pharyngeal function, dysphonia, dysarthria, dysphagia. We see here we're kind of getting some of the cerebellar tract as well. We see that there's also some trigeminal tract involvement here too. So we know that it's more on the lateral side. This is going to be lateral medullary symptom, and like we said, pica is right here. Really gets the lateral portion of your medulla right here. So we have an infarct really on the right-sided pica. So this is pica, posterior here, posterior inferior cerebellar artery. So this is a pica lesion. All right, and on to our last one. Touch yourself here. You got right-sided tongue deviation, left-sided hemiparesis, and right-sided body, not face, loss of sensation to light touch and proprioception. So question is, where are we? All right, and the easiest way to know where we are here is going to be 12. So you have 12. Remember the rule of 4. That means that you're in the medulla. And we also have another thing that we know that's medial. Here is going to be your medial meniscus is messed up. So sorry, this should be left. Sorry for the mistakes. So we're going to left. All right. So this is left-sided loss of sensation of light touch and proprioception. We know that the medial meniscus is affected here in the medulla. Remember, it decussates in the medulla a little bit lower than this. It's ascending tract. So it's going to be contralateral. It's going to be contralateral loss of your sensation of light touch and proprioception. All right. So we know that one, we're in the medulla. Next is, are we medial or lateral? Hypoglossal nerve that goes into 12, right? So it's cranial nerve 12, so it's divisible by 12, and anything that's divisible by 12 is going to be more medial. So we know that we're medial because it's affecting the hypoglossal nerve. We also know that we're medial because we're affecting your medial meniscus, so M, with this loss of sensation of light touch, and you're affecting your descending motor tract with corticospinal tract with left-sided hemiparesis. So where are we? Perfect. We are right here, and this is going to be our last one. We have a lesion right here, affecting your hypoglossal nerve, affecting your medial meniscus right there, affecting your corticospinal tract right there. So you're going to have that corticospinal involvement with contralateral hemiparesis. And you're going to have your medial meniscus involvement with contralateral loss of sensation and proprioception, light touch and proprioception, and you're going to have that hypoglossal nerve dysfunction causing the tongue to deviate to the ipsilateral side. So lastly, this is medial medullary syndrome. All right. And what is going to be affected? A lot of times you can see that there is the medial aspect of the medulla here, and it's going to be your anterior spinal artery. All right, so review all of it. You can take a picture of these, but this is all going to be your midbrain cranial nerve, pons, medulla cranial nerves, your ascending and descending tracts. And not included here is going to be your sympathetic tract as well, which is going to be lateral. It starts with an F, so that's like a little bit of a hint there. And then you're going to have your infarct. So Weber-Benedict syndrome is going to be mostly your PCA and your SCA infarcts. All right, so which are affecting the midbrains. Your lateral pontine syndrome is going to be ICA, right? Because that is supplying your lateral portion of your pons. So ICA here, and your lateral medullary is going to be your pica, supplying the lateral portion of the medulla, and the medial medullary is going to be your anterior spinal artery right there. And that is it. Thank you.